Hello, everybody, and welcome to the Doctors of Running podcast, where we, a group of doctors of physical therapy, discuss the art and science of running and the stuff that we put on our feet. Today at the round table, we have the founder of Doctors of Running, Dr. Matthew Klein, and myself. I am Nathan Brown, and we are going to be having a really fun episode where we start to talk about various conditions. And although we cannot give specific recommendations, and there is no evidence to definitively say what is going to help each regarding footwear, regarding prevention, regarding recovery, we are going to talk about common things that we see both in the literature and also within our own clinical experiences and just some pearls that we may have for you. So before we do that, I'm pretty sure Matt is basically doing this episode from a hot box in his garage.
Yep.
So if you see him sweating, you can understand why.
And apologies for the constant, me getting sips of water so I don't pass out, because it is 95 degrees outside and I don't know what temperature it is in this garage. But
oh my gosh, brutal.
The things I do to make sure I have a good background.
Well, for me, I am in a chilled, unfinished basement. So
that's nice.
Yay. In Wisconsin, which very different weather patterns.
Yep.
So what we want to do before we go into that episode is talk about the shoes that are in for testing. So this is our in for testing segment, which is powered and fueled by Scratch Labs. If you want to try out Scratch Labs, which has great different hydration and nutrition options for endurance athletes, you can use the code Doctors of Running. That gets you 20% off your first order. But let's talk about what we are testing right now. Do you have anything that you've been getting miles on?
I've got 4 things right now that I'm getting miles on. So the first one is the Hoka Arahi 8, which was a pretty big surprise to me because they completely redid the shoe. It does not feel anything like prior versions. So J-frame's gone. It's now what's called the H-frame, although there's a pretty significant amount on the medial side. The other thing is there's actually some room in the upper, so there's no longer the super snug, narrow fit. So people that that, sorry, more room in the upper. It's still a Hoka fit, so it's not the widest thing in the world, but there's more width and volume. The midsole is also, and for those trying new Hokas, you got to let them break in. This shoe came off as really stiff and firm initially. Gave it one run, softened a little bit, so it's definitely softer than the prior version. Just needs some time to break in. It's not as biased as the prior version, but it's still got a lateral push there. So people that want that and want the kind of medial stability, it's there. There's just also some lateral stuff, and they did not get rid of it going into the forefoot, which is absolutely really, really nice. So doing good so far. Not the fastest shoe. It's actually, I think, heavier than the previous version based on my own measurement, but it's better cushion and a little different stability. Cool. The next one I've got is the Nike Structure 26, which I was really excited for. Also, similar situation where version 25 was really firm. This version is now a little bit softer, feels pretty blocky in the heel, but the heel, there's at least a lateral bevel in the rear foot that makes it smoother. It breaks in, not light. It's a heavier shoe, but it's got a good, it's just a good trainer. So definitely a little bit more prominent medial stability than the last version. And they kind of fixed that a little bit, and midfoot filled in. So definitely more stable, not as quick. So not as bouncy. I feel like the last version was snappy firm, even though it was heavy. So you could pick the pace up just a teeny bit. This one's for easy miles only. So I really want to know what's happening with the Structure Plus and Premium. I really, Nike, I don't know if you listen to this. I'm sure everything's already done, but anybody working at Nike, please tell me the Structure Plus is like a stability lightweight trainer. That would make my day. The Vomero Plus was not. I also have that shoe. It's not quite stable enough for me, but I do appreciate it. I just thought it was going to be a lot lighter.
Sure.
But it's fine. That's fair. It's okay. I don't, but Structure 26. And then the last two is the Brooks Hyperion Elite 5 and the Hoka Rocket X3. And so I was very excited to try the Hyperion Elite 5. It is very light. It's got a classically bouncy Piba foam. It's unfortunately not stable, and I am struggling with this a little bit. For shorter distances, it's fine, and it's been good. The heel is the best part. Forefoot is really stiff, really rockered, but getting on the heel and rolling through this, it's a massive improvement. We didn't try the Hyperion Elite 4 PB, but over previous version, it's much better. It's just really different. It's not the classic, I would have expected, wider fitting, more stable. It's exactly the opposite, where it's actually way more snug and narrow and really aggressive and not very stable. It's fine when you're like up to speed in it, but just not a shoe I would use for longer distances. But the Rocket X2 or 3, sorry, the Rocket X3 is doing super well. I am really liking this. This is supposed to be the more stable now, the two shoes, and they've done a great job. My 2 workouts in this have been awesome. The foam is snappier, a little bit firmer. The fit's been fixed. The weird like offset where I felt like it was going over a speed bump because it has been fixed.
I was wondering, that was going to be my question.
Yep. Slightly higher drop, which takes a little bit of stress off the calves. Really nice post-shot bevel. This actually might be my racing shoe of the year. My only concern is I'm really scared I'm going to rip this off.
It's the perfect pod for you to rip off, Matt.
Yeah, I'm like going to cry when that happens, and I know it probably will. But so far, like stable neutral, really good. Really maintains that well, if not better than the last version, because I feel like they just improved the transition. It's so lighter,
less of
faster.
Like the negative drop feel on this one compared to the last one.
Does not have that. Still feels lower drop. Doesn't quite feel 7, but that's probably just compression of the midsole. But
and then when you say that it's firmer, are you saying firmer than other super shoes or firmer than the previous version?
I think it as it breaks in, that's going to be so firmer is not the right word. I would say it's snappier and more responsive.
Gotcha. There we go.
That's firmer helpful. Was the wrong word, but yeah, the fit is also, even though the length is better, it is more snug. So be warned. But yeah, I'm loving this thus far, and I'm going to cry when the heel piece comes off.
Yeah. Well, that's great. Well, I've got one shoe that I want to talk about, and you're going to have to fact check me on this. And it's a shoe from Altra that I have just started testing. I do not have a lot in it yet, but it's one of those we test enough shoes that we kind of know if we're going to like something or not early on. And sometimes shoes surprise us and they change, but the Experience Flow 2 from Altra is awesome. It's one of their 4mm drop shoes. This would be like their neutral kind of daily trainer. It is unrecognizable from the previous version. And this is where I need to be fact checked, because when we first tested the old version of the Flow, it was called the Ultra Forward Experience, I think. So
I believe you're right. Yes.
They rebranded it. They rebranded it to the Flow. When we first got it, it was the Forward Experience. But the midsole in the new version is incredibly softer, like very notably softer. It's probably the first Ultra that I would actually call soft, where I feel like most of the softer, more plush shoes that they offer just have more stack, but not really a lot of compliance. This one actually has compliance. So that's one major difference between the older version and this one. The other difference that comes along with that is the stiffness of the midsole longitudinally from front to back. So in the older version, because of how firm the foam was, there was not a lot of flexibility in the forefoot. You can kind of see that there. But with the new version, it bends like crazy. So you get a very natural running feel. And I am just loving it. The fit is really good. A lot of Ultras lately have been, and there's one of them that got sent that still is this way, that are just too snug at that transition between the midfoot and forefoot. It's just locked down too much right over the ball of my foot. I wish they would just open that up, but this one is not too snug there. So fit is good. Right. I love the feel of the midsole. It's softer, so it's 4mm, but if you like lower, it even feels that way because of the dynamic drop as you load it. And then I just really like the forefoot flexibility. So very excited about getting more miles on this shoe, and it's a good time. I really like it.
A really quick thing, not to fact check you, there was an Experience Flow 1. It looks like, and I had totally forgotten about that, but I didn't realize that they were basically transitioning this into the forward, and that was transitioning into the Flow 2, if I'm hearing you correctly.
Yeah,
interesting.
From what I know, they originally called the Experience Flow 1 the Experience Forward, and then they changed the name. If somebody is on YouTube and can tell me I'm wrong, please do
fact check us.
And maybe if there's someone from Ultra watching, you can fact check that. But I'm pretty sure that's what happened.
Yeah, I will say, and this is a hot take. Sorry, Ultra. I thought the original Experience and Flow shoes, the midsoles were not very good.
They were too firm.
They were way too firm. And so, and some people are going to love that, right? The Forward Experience actually, I kind of liked it for picking because it was 8 ounces. You could pick up the pace. And I surprisingly did unintentional workouts in it. When I put the Flow 2 on, I was like, oh, this is better. okay, this is going to be more comfortable, not as snappy and fast, but it was going to be like, okay, this is going to be more, what's the word I'm looking for?
It's a cruiser.
It's more cruiser. It's going to be more, this is not the right word, but accessible to people.
Yeah.
Like, there's certain people that do
more.
Yeah.
I think this can do more than the previous one. I think the previous one just felt too stiff and firm to like enjoy at a variety of paces. This one now is, cushioned enough to enjoy a chill run and has that flexibility, but it's light enough to do more. So I think it has a little bit more versatility, but that's coming off of early test miles.
Yeah.
So I shouldn't sing its praises too much yet, because I have more to put on it. So that's what we're have in for testing right now. Again, if you want to check out Scratch Labs, you can use the code Doctors of Running for 20% off your first order. If you're trying to get the most out of your next training cycle and you're trying to make sure that you're making the right decisions to get you to the goals that you want to achieve, sometimes it's nice to have additional tools in your tool belt. Stride has its generated workouts, which is going to personalize workouts based on the other efforts that you've put into your training before that. And so if you're wanting to have a little bit of assistance based on the data that your own body is giving you, you can check out stride.com to learn more about their generated workouts and other things that the Stride pods can help you achieve in your training and in your racing. So head on over to stride.com. That's STRYD.com to learn more. Before we get to our main segment, Matt, I'm going to ask you a question that you didn't know I was going to ask you.
Okay.
It's about me. So I'm going to have you kind of diagnose me on air.
Okay.
So I have been pretty consistent in my increasing of my running mileage overall.
Okay.
I did a longer, like 2-hour trail run, weekends, or last weekend now, a whole week ago. And then I kind of took a down week this week and I haven't ran in a couple days. I've been having some dorsal sided foot pain.
Okay.
And I think my brain starts to get scared when I get dorsal sided foot pain. So I'm like, is this a metatarsal stress fracture? Is this like a chronic Liz Frank type injury? And we can talk about what those are. But I'm also like, should I just keep running? What would you do if you were me, or what questions would you ask?
Yeah, I think the first question is that 2-hour trail run something abnormal for you? Is that did you work up to that, or is this an abnormal out of the blue? Like, I just suddenly jumped to 2 hours.
No, the timeline is similar. I've done like an hour 40, a couple hour 45s, an hour 52. So I have a lot longer runs in there. It's definitely my first vert day. So Stevens Point is flat, super duper flat. Yeah. And the trail, so when I say flat, when I was marathon training, I would run 20-mile training run and I would get 112 feet of vert. And I would look for the hills. I ran on the Ice Age Trail and we got I think it was 1,500 feet of vert, or 1,300 or something like that. So very different in terms of the amount of incline, decline, and running on sideways.
Got it. Okay. Can you describe where exactly in the dorsum of your foot this is?
If this is my foot, this would be my big toe. It sits kind of from the midfoot towards the forefoot, kind of moves between the second and fourth metatarsal.
Got it. So not really proximal, not super distal, kind of in the middle is what you would describe this as?
Yeah, but kind of vague, kind of moves around.
Okay. So not consistent. So there's it changes location. Okay.
A little bit.
Yeah. That's not a bad thing. What I'll tell people is don't panic if you're I feel like it moves. That's information. And then we'll be able to go, oh, okay, because different things will tend to move or be more consistent. So that's not an abnormal thing. It's great information. How did it change from that run? Did you have any symptoms beforehand?
Nothing before it, and not even during it. And then I would say I started to feel it 3 or 4 days after. Okay. And it, I feel it most when I'm putting weight through my forefoot.
Okay. Got it. So not so much when you are if you're initial contact, heel strike. Do you feel it walking, running, both?
And it's not even pain. And I don't really feel it like pain. I can kind of feel it when I'm walking. If I just stand and put weight through it, sometimes I'll feel it. Sometimes it'll feel a little bit tighter on my shoe, almost like there's some swelling in there.
Okay.
I'm not sure.
Okay. But if you go for a run right now, are you going to feel it?
I ran on Thursday and I really didn't feel it.
Okay, got it. But so it's been more like occasional walking, standing.
Yeah.
A little less consistent, it's sounding like.
Yeah.
Okay. All right. That's actually kind of a good sign. So that's positive. If it's like more consistent, like, oh, ow, 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 then I get kind of a little more worried. The less consistency is like, okay, all right, this is actually a good thing. Where can you describe it? So you use the P word, but is there any other words that you use to describe it?
Yeah, and I don't even think pain is the right one.
Yeah.
It feels like pressure. Pointed pressure. I would say the most pressure I feel is between the midfoot and the long bones, like the metatarsals of 1 and 2.
Got it. What have you done for it so far?
I have not really done much.
Got it.
I've done a little bit of needling of like my calf, like lateral complex, and then anterior compartments, like tibialis, anterior, and fibularis muscles.
Is there anything you can do consistently to reproduce it? You're like, oh, every time I do this, for
loading
sure.
it.
Okay.
Loading, like just putting weight through the ball of my foot.
Okay.
Probably the most.
Okay. Is there anything you can do to change that? To lessen symptoms?
Sometimes when I activate like my intrinsic muscles, I can feel it less on the top.
Okay, got it. So if you activate intrinsics, it reduces that. Correct. Is there anything else?
That's pretty much it.
Got it. You notice any like time relationship to this, like throughout the day, any change of like morning is more prevalent or evening, or no, it's more, sounds like activity specific, like if you load it.
Yeah.
Got it. No, nothing at night, right? No symptoms, nothing like that.
No.
Okay, great. That's good. The reason for the listeners that I frequently ask about night symptoms is oftentimes in PT school, by the way, they scare the heck out of us and go, any night pain is cancer. And you're like, and then you get to clinical practice and you're like, well, oftentimes night pain is actually more consistent with something being really flared up, like an inflammatory kind of thing. So if it's not, that's great. That's really, really good. And so it sounded like loading can bring on the symptoms. Obviously not. Do you get any symptoms when you're not loading it or just sitting there?
Nope.
Great. So if you're not loading it, no symptoms. If you can activate musculature around it, it reduces symptoms a little bit. So I'm a little bit less concerned about it being one of the major muscles or something like that, although I haven't done so it's my brain's going, what's the tissue source just based on this stuff of going, is it bone? Is it ligament? Is it muscle? Is it tendon? And a lot of the stuff, especially the delay in symptoms, is making me go, I'm a little less concerned about this. This is good. Hearing the fact that it sounds like irritability is fairly low, correct? Right? Severity is fairly low. Nature kind of starting to not 100% yet, would definitely need a little bit more like testing to figure this out. You said you needled your calf, but haven't really done like anything there. That's the hard part. Like I could have asked you, like, did you put a tuning fork on this? And that's not even the most accurate thing.
Yeah,
either,
I did. I did do some soft tissue to kind of extensor digitorum brevis.
And
I don't know if it really made a difference. That's for the listeners. That's a small muscle that starts and finishes within your foot on the top part of your foot.
Yeah.
So
the pattern is a little bit less consistent, which isn't a bad thing. What shoe are you wearing?
I did the Tecton X3 for the trail run. Yeah.
And you have experience in that shoe previously? Yeah. You do. Yeah. Got it. Yep. Did you? And you said no discomfort during the run at all? No. How's the progression been since that time? Staying the same, getting better, getting worse?
It's just kind of been there. I would say since I think the other thing I did for it is take time off. So I haven't ran since Thursday. It's Sunday right now. So I've taken a couple days off, and I did go on a 5-mile walk yesterday with Jana. We went out to the state park and we were walking around, and it was nothing. And then it would come for a little bit, and then it would go away, and then it would come, and then it would go away. Did that twice during the walk.
Got it. But not consistently like, it's like now it's every single time.
Correct.
Okay. So
not a progressive worsening.
Yeah. Did it force you to change your gait or no?
It didn't force me to. I have sometimes to try to put less pressure through the ball of my foot.
Yeah.
But I didn't have to. It didn't hurt so much that I needed to switch.
Got it. So irritability and severity is still pretty low. like nature. I'm doing what's called the SINs, by the way. And I'm doing this because I'm literally making an orthopedic course from scratch right now, going, how do I teach this stuff? Nature's still a little bit up in the air, but I'm less, the consistency stuff makes me less concerned for more serious stuff. And I'm kind of almost like kind of leaning toward like sheath kind of stuff, like extensor sheath and things like that. But that's an unknown. Stability sounds, it's pretty stable. Like it's like you can reproduce it. It's not too bad. So I'd say that's really good. There is some level of consistency, even though it's not 100%. And then stage still sounds early, like, or at least maybe not early, but like not inflammatory, not, not chronic. This hasn't been going on for a while because you haven't had this before, right? No history of this.
Well, I think this is another factor for me is this is my foot that I've had issues. So this is where I had my plantar plate tear. This is where I had like my 5th metatarsal issue. It doesn't feel anything like either of those. It's a very different location, different sensation. But I think because I have this foot having a history, I get scared.
That makes sense.
When
that's
that
a normal
stuff
experience.
happens.
Yeah, that's a normal, that totally makes sense. That would be a normal concern.
Yeah.
However, hearing this, I would go, hey, there's still some testing I would want to do. And the fact that you can actually reduce the symptoms with intrinsic stuff is like, that's great. I would say, unless it starts to get worse. And your original question is, what should I do with this? Right?
Yeah. Should I keep running? Should I
if
do
I was
a couple of weeks of biking?
I feel like the symptoms, and you can tell me if I'm wrong, aren't bad enough to not run. I would still see if you're like, hey, can we modify some, like find a shoe maybe that tends to reduce symptoms, maybe something that's a little rockered.
Yeah, that's what I was thinking.
Just to reduce some symptoms there, just in case in the meantime. But I don't think I would say time off just because the irritability and severity are so low, and it doesn't smell or sound like bone stress, although I could be wrong, and you're going to know that better than me because you've actually had one before. Yeah. So it feels similar or different?
Different.
Yeah.
Maybe.
And you can tell me. You can tell me.
Reality
if I'm wrong.
is, I get less objective when it's me.
Yeah.
So
this is not evidence based at all, but I've had several people that have asked this, and I should do a qualitative study, even though I don't know how to do qualitative. Most patients who have had a bone stress injury before, I would say almost 100% of the time when they're like, I'm like, hey, does this feel similar or different? They're like, their answer is almost 100% right. Like if it's been a bone stress injury, like this feels the same. If it hasn't, it's been like, no, it feels like something totally different.
Yeah.
But it gets hard when you start panicking a little bit. So I would say, I think you're fine to keep running. You have to do a little more objective tests to kind of figure out like what this is in terms of like continuing with palpation, a couple like, squeeze tests and stuff like that.
Yeah,
but given
that was
this,
negative.
So given the severity and your ability being low, I think you're clear to keep running. I would just make sure to have a rocker of some kind to reduce some of the load at the moment, but then don't be afraid to slowly start reintroducing that load because you don't want to totally unload something. But I also would say don't jump 1,000% back into running. I think you still, like with the week off, take some time to build back up, I think would be important.
Perfect.
How's stress? How's stress and like sleep and nutrition and stuff like that?
Pretty normal.
Sweet.
Nothing weird there. Yeah.
Great.
Fantastic. Well, thanks for going on that journey with me, man.
Yeah. How long did that take? What, 5?
I don't even know. Yeah, something like that.
All right. For all my students who think I can't do a subjective in less than 15 minutes. I'm in like the creation of the testing right now. I'm like, how long do I give them for this on the practical exam?
Yeah. Exactly.
I went back and forth with my director, and he's like, "You're being way too aggressive." I'm like, "They'll be fine." He's like, "I'm pulling you back on this. You got to give them more time."
Oh, that's good.
I wonder if any of them listen to this. They're gonna panic because this will be out long before the course starts.
It's funny. Some of the students that I get to work with, they make fun of me because they'll like in our lab environment, which is really like flowy and open and really interactive. They'll just like, we play music most of the time. So like music playing, students are learning. It's really fun. And sometimes one will go up and they'll turn on the DOR podcast with me talking just to make fun of me. Like, funny. I heard this really good new podcast and they're just making fun of me. So it's a good time.
That's awesome.
All right. So we're going to dive into the main segment of this podcast, which is talking about various regions of pain, why those regions sometimes develop pain, and then kind of this conglomerate of what can we do about it? What sort of shoe wear recommendations can we have? And how could we maybe prevent it in the first place? And so, as I have said when we introduced the episode, these are not medical advice. This is not specifics as to everyone can do this and you're not going to have pain or it's going to perfectly rehabilitate you. This is going to be overarching things that we've learned through the literature as well as our clinical experiences. So what we're going to start with are two different causes of and regions of foot pain. One of these is plantar surface, so like the bottom of the foot in what we call the forefoot. And then we're going to move in and talk about the heel. So when you work with runners, what are the most common causes of pain in the plantar surface of the forefoot?
So most common thing that people get diagnosed with is going to be plantar fasciitis, or plantar fasciopathy is a better term. How often that actually is the source is not as common what people think. So you can totally there's a lot of musculature in that area. Very, very common to have some strains of some of the small intrinsic muscles. And that happens all the time, especially medial arch too, like plantar surface, medial arch. That's really you were asking about heel or just plantar surface?
I was saying the forefoot of the plantar surface. So like by the balls of the feet.
Okay, got it. I want to beg. Am I answering this correctly?
So probably not plantar fascia pain.
No.
Probably not
so
that
never.
one.
So totally wrong. Yeah. So let me make sure I'm listening as this gets hotter in here and I'm sweating more. So forefoot area. So a couple different common things. So just a little like bone bruising or something can also happen very frequently in like the bottom of the tarsal heads. You have two bones called under your big toe called your sesamoid bones, which can also get really irritated sometimes. That's really common because they also have a ton of tendons that connect in there as well, and tendons that go through them. That's a common thing. Ligament sprains are also not uncommon, especially among trail runners who they're in a flexible shoe and they go a certain way and feel something in the forefoot. That's another one. Tendon insertional stuff is something I've seen more common. And then obviously, although this is a little distal, you can get some nervy related things. And then the freaky one, the scary one is like bone stress stuff, or some, not all of the kind of common things that I'm thinking off the top of my head. And we're talking forefoot.
The only one, and you mentioned nervy things, I think the one that's most common in the forefoot by the balls of your feet is what's called a Morton's neuroma or interdigital neuroma. And it's kind of a thickening of the nerve as it's passing through the end of your kind of long metatarsals. And that nerve just starts to get irritated. People usually say like it feels like you're stepping on a pebble. You might get some numbness and tingling up into your foot. It hurts to squeeze your foot, things like that. So
there's actual squeeze tests. So there's actually a couple of different ones now, but
So when we think about, what leads to that, and therefore what can we recommend from a shoe perspective, like how when we consider load for those areas and how shoes could play a role, what would you think about?
So the way that shoes are going to play a role in this conversation is that you're typically in the early rehab phases or early like management phases, you're trying to reduce load. Okay, you're not trying to increase it. And there's a lot of load that goes through your forefoot. In fact, that's actually probably some of the highest loads you can get. Like you get, if you're a forefoot striker, obviously during initial contact, but some of the propulsive forces, like we know now that actually some of the greatest stresses to bones actually happen from muscle contraction. So like when you're pushing off, muscles are contracting really hard. So a way to reduce some of the load is you can reduce some of the movement there with something like a forefoot rocker. And I want to clarify when I talk about a forefoot rocker, it needs to be really specific. If the forefoot rocker is holding you up in a bunch of extension, that may not necessarily reduce load. We're talking about the curvature under the forefoot, but it still keeps the toes in a mostly neutral position that allows you to roll off that and not have to use your own natural forefoot rocker, which does require some additional load. It's efficient, but there's some additional load and range of motion and strength requirements that if you can use a forefoot rocker, you can reduce some stress in that area.
Yeah, I think that's super important to think about because if we go to probably two of the most common ones, we'd probably see what we call metatarsalgia. So like just pain at where you can get some irritation and bruising to the soft tissues that are right under the ball of the foot, or looking at sesamoiditis. So those two little floating bones at the base of the foot, you're going to want to offload those. And so you need a shoe that's going to do that. We know that if you have a stiff rockered platform, again, not one that's holding your toes up, that decreases plantar pressure, which means pressure underneath that part of the foot, and it's shifting in other places. But if we want to offload that rocker is going to be important. And it can't just be the shape of a rocker. Like you can see, I'm holding up the shoe I talked about today for what I'm testing with the Ultra Flow 2. And you can see if it's just sitting here, you can see there's a bit of a rocker, but it's super flexible. And so this isn't going to do anything for you from an offloading perspective. It actually would be doing more in their old version, though I wouldn't recommend it because of some of the, like how firm the foam is. But like now this one's not bending. You need that stiffness. On that front, I think something else that's nice is finding one that is compliant enough where it's not just like directly pushing back into your foot. And then the last part that I was thinking about, and it's actually nice that I have an Ultra shoe here, is
I was going to say,
a wider space, because either you're going to have to modify what's going on underneath your foot with some kind of like temporary orthotic stuff, or you just want enough space, especially if you have like a Morton's neuroma. If you're having a shoe that's pinching your metatarsals together, that's pinching on that nerve and causing that irritation. You want a shoe that's allowing your metatarsals to really splay out. And so I'm not saying it's every Ultra, because like I said, some of them are pinching me where it's actually problematic for this. You need a wide midfoot to toe box for that toe splay.
I will say the toe box part was the other important piece, that if somebody is going to get a shoe for this purpose, we're going to make some recommendations. Ultra, I'm glad they have some 4mm stuff now, because my actually go-to company for a lot of the like medical or like tissue stuff is actually Topo, because they're not usually zero drop. They've got that wider, more anatomic toe box, and not all of them, but a lot of their shoes tend to have a little stiffer rocker so that people can handle that. So that's been a go-to suggestion for people. And the toe box width depends on the person, because everybody has different width feet. Somebody with a really narrow foot may not work as well with that, but for people that need to, like, especially so that the poor metatarsals that being compressed, because what we suspect and there's some different thoughts on this, some of the Morton's neuroma, is that if you put pressure on a nerve, tissues respond to the stress placed upon them, and they sometimes grow out in response to that, where you get that enlargement of the nerve. So if you have a narrow toe box, you got toes getting crunched together, that puts more pressure on the nerve, and you want to create more space there. Somebody's a narrow foot, you don't typically need a super wide shoe to do that. Somebody who has a wider foot, you might need to have a conversation going, you may need to start thinking about a more appropriate toe box and anatomic stuff based on what you're experiencing. So because Topo typically does the drops a little bit better, I know Ultra's now working on that. Topo's been a go-to, but now with some of the Flow and some of the other shoes, we may have some additional options for those of us looking at this from a medical and rehab management standpoint.
Totally. Before we start talking about what can I do to prevent this from coming, I want to first talk about another region of the foot. Now we're going back to the plantar, the bottom surface, the heel, typically where people are having what they may just call plantar fasciitis, although we've talked about in previous episodes, can be a lot of different things. Let's just start there. What are some misconceptions that people have about plantar fasciitis?
Yeah, one of the biggest things is that the more common one that I've heard recently is when I say, oh, you have this plantar fascia thing, and they're like, I have plantar fasciitis. I'm like, no, it's a tissue. It's a really important tissue. Like, just because you have irritation doesn't necessarily mean it's that. And just because I talk about this, I'm not talking about a pathology. It's a tissue that you need. It's actually super important for like your progression of gait, for natural stability and all kinds of stuff. So you need it. I just worked with somebody who had their plantar fascia rupture, actually.
Oh, wow.
And he's actually going to know who I'm talking about because he listened to the podcast. But yeah, apparently too many cortisone shots and he can correct me if I misinterpreted that when we were talking. But yeah, it's unfortunate. So it's a very important mechanism on the bottom of the foot, and there's a lot of misconception about it. There's also a lot of misconception about treatment. Like, there's a lot of gurus out there going, this is the perfect treatment. And honestly, one of the best things we've found is like time. Like, it just takes time. To be honest, the clinical practice guidelines are really frustrating for plantar fasciitis.
Yeah, they are. I think it's a tough one, because we've talked about this, and if you want to tune out for the next 2 minutes, you can. But just tagging the suffix itis onto something says that the reason why you're having this problem is because of inflammation. And it's saying this is an inflammation-related problem. And I think that's one of the misconceptions about plantar fasciopathy would be a word that I would use that in place of this, or plantar fascia pain, because the tissue itself can be pain generating without any inflammation. And that's important because when it's inflammation, you treat it with anti-inflammatories. This is oversimplification, but in general, you're going to take things that are going to calm down inflammation. Maybe that's ice, some sort of cold, maybe some sort of non-steroidal anti-inflammatory like ibuprofen or something like that. But a lot of times it's not a true inflammatory condition that's leading to your symptoms. It's changes in the tissue quality, which is leading to some sort of pain sensation or something else completely, because there's lots of different nerves that pass through here and other tendons that can cause pain that mimic plantar fascia issues. And so I think that's one of the biggest misconceptions, is what's actually causing it. And that does mean that the treatment looks very different, because if it's not inflammatory, you're really thinking about optimal load management. You want enough load to make sure that you're continuing to promote healthy tissue, but not too much load to create irritation. And it's honestly a real bugger of a condition, not because it can't be helped, but because how it gets helped looks different for every single person. But along those lines, we're going to go into kind of this kind of tricky topic. What do you recommend for people to do the best to maintain a healthy foot from heel to toe? Like what things, if I could do these 3 things, it doesn't need to be 3, what would you recommend that people do to keep their feet healthy?
Let me clarify, by the way, that this is not bulletproof. That when
100%.
we talk about trying to keep them healthy, running all this stuff, people get injured for a variety of reasons. And it's not always because of the activity you're doing. You may have heard me ask Nathan how his sleep, nutrition, all this kind of stuff. There's all kinds of things that influence pain, injuries, and things like that. So this stuff is good. It will not prevent it totally, because stuff happens, but it certainly can reduce your risk for sure. So one thing that I really, really, really enjoy is the first thing is going to be any kind of strength training, any kind of stuff that gets you out of a shoe, that starts working on appropriate loading with higher intensity, lower rep ranges, that builds some resilience, be it bone, be it, the muscles in the area. A good strength training, a little power training stuff can be very, very helpful. And it doesn't have to be 1,000 things, just like 1 or 2, like little like heavy weighted calf raises, maybe some double limb hops that when you're barefoot, like things that really engage some of the foot muscles. Less can be really, really helpful, just because we know strength training tends to do a little bit better job of reducing risk of injury. The other thing that I would really encourage people, if they are able to, and not everybody can do this, is to spend some time barefoot, be it like around the house if possible, not all the time, because that can also put you at risk for things like plantar fasciitis and irritations, but just spending a little time outside of shoes, just going kind of like just expose my muscles to working a little bit, things like that. Not everybody can do that.
I'm smiling, Matt. I'm smiling because I was thinking, how am I going to recommend that people spend time barefoot or in some sort of minimalist shoe, knowing that that's not appropriate for everybody? So you like said the exact thing I wanted to say of like,
it's like,
we know this isn't possible for everyone, but if you're in the category where it is, do it.
Yeah. Like if you happen to have a minimalist shoe, like I love Zero, by the way, and then it's a great shoe to walk around, and they actually make a leather version, which has been great for more professional thing. I've gotten some good compliments too, but I think that's also because a lot of my students wear Zeros as well. But it's a great way. I just have to be careful because I know if I wear them for like a long day, my feet are going to ache. So you have to be kind of strategic in building up to them. But that's another really good way. Those would be kind of my big 2. I think this is always up in the air. And for people that are hypermobile, this may not be the best option. But if you're someone that's a little stiffer, just working on a little bit of mobility would be helpful. And just going, can I make sure I have some range of motion in my ankle, some my calf, making sure my big toe joint moves. Because like once you start losing that stuff, it really changes gait. So if you could do that a little bit, that's great. For people that are hypermobile, that's probably not the best option because you already have a lot of motion. You're going to probably want to focus more on strengthening and stiffening. But those are kind of be like big three. Would you have any other ones that you would add?
Yeah, the ones that were in my mind were one of them had to do with the control and robustness of the muscles of the foot, the intrinsic muscles. So in that category, I had two things. One is to, if you can, go barefoot or use a minimalist shoe for daily stuff. The second thing would be while you're sitting in your office chair or at breakfast or whatever, doing toe yoga. And so if you just YouTube toe yoga, you're going to see lots of different ways. But the idea is you're just learning and practicing how to move your toes independent of one another, which is activating all of these intrinsic muscles. So for me, thing one was, hey, work on your intrinsic foot muscles, get them active either through barefoot walking or toe yoga. The second thing that I was going to recommend is if you are someone with less mobility, work on making sure you have enough dorsiflexion at least, like at a minimum. And so there's a really nice exercise that you can do a stretch and a mobilization of your joint at the same time, where you put like a little belt underneath your malleoli that goes across the front of your ankle and you kind of lunge into it a little bit. And you just kind of rock back and forth and work on some getting your, shin over your toes, just working on enough of that motion. So a way that I have recommended kind of like on your own testing if you need more mobility is go do like a half kneel by a wall. Take your hand, the width of your hand, and move your toe that far away from the wall. And then if you can't lunge forward and touch your knee to the wall without your heel coming up, maybe work on your dorsiflexion range of motion. That's usually a recommendation that I have for people. So thing one was the intrinsics. Thing two was enough ankle dorsiflexion range of motion. There's more complexity, but again, I'm going with like, if you've only got a couple things. And then the third thing that I was going to say was total soft tissue mobility. So calf length and hamstring length. So everything on the back side of your leg, just making sure that you have enough flexibility there. Again, if you are someone who doesn't have a lot of length, then you should stretch and make sure that you have enough. So that'd be my third thing. And then I was going to add calf strengthening as well. And just having a nice, strong, lots of load through that calf complex, knowing that the calf and the muscles that line the deep compartment in our calf, like our tibialis posterior and some of the other flexors, those, if we can keep them strong, they're going to support the arch as well. So
absolutely,
those were going to be my four. So I think we were on the same page with a lot of that.
That's great.
Okay. We're going to do one other pain location and we're going to talk about some of the similar things. And this is like anterior knee pain. So we're not talking about like meniscus things. We're not talking about that kind of stuff. We're talking about kind of this, I've got pain either on my patellar tendon or underneath my kneecap, kind of right in the front. So the first question I want to ask you is, what are some potential things that are causing pain in that region?
Right. So one of the big ones, obviously, is like patellofemoral. They call it patellofemoral pain syndrome, which can be 1,000 different things.
Right.
But you can have a really common one that I see in run. You said underneath or behind, you're just generally in that area.
Yeah, behind. It can be behind the kneecap, like inferior or below. Yeah.
So if somebody's got symptoms behind the kneecap, that can sometimes be a little bit of what's called patellofemoral syndrome, where you've got the patella, the back of it's just a little bit irritated. It might be moving a little bit too much in one direction, or you might have some hip stuff that's going on. You can have referral. The other thing that's really common is patellofemoral, like tendon, like a patellar tendon, tendinopathies are really common. The tendinitis are not as common because it's hard to tell when they started. By the time when they actually flare, most of them have been going on a lot longer than, not to freak people out, like tendinopathies, you don't have to have pain to have a tendinopathy. Like they go on for a while and then suddenly they flare their head and you're like, and don't ask us with no idea. Like, I wish I could tell you, this is absolutely the reason. No, you overloaded it long beforehand. It's just for whatever reason, the weird combination of stress, inappropriate sleep, nutrition, overtraining, like some weird combination made you have symptoms. So it's that complex, but those are two really common ones that I observe. The other not as common one is there are some people that can either get referred hip stuff into the knee or hip or lumbar spine, as well as sometimes some people with IT band stuff. So some of the connections can sometimes cause some patellofemoral type stuff, but the actual like strain of the tissue of like the tissue behind the patella, as well as like tendinopathies of the patellar tendon are the kind of really big ones. Are there any ones I'm missing?
The only one I would consider adding, depending on kind of your family history and your age and like previous injuries, that's another area where you can have one type of osteoarthritis. So if you have like retropatellar osteoarthritis, that's where you could start to get some discomfort there as well. So let's talk about how shoes interact with this region. So how confident can we be that shoes can influence anterior knee stress? And I think we're particularly talking about anterior knee stress and not like medial knee stress or lateral or posterior.
I will be honest that as we move further away from the ankle, I get less confident with how we can influence this stuff. And I say this because I've seen this go. I'm going to say a few things. I'm going to go, and I've also seen the opposite happen when we have these factors. So like the stereotype that you probably see is going, I would expect a lower drop shoe and a less rockered shoe to reduce stress on the knee. I have also seen the opposite. I would also assume that a higher heel drop, meaning the difference between the front and the back of the shoe in terms of height, would increase the stress on the anterior knee. I have also seen the opposite happen, right? Because we know that like higher drop rockered shoes tend to increase workload up into the knee and the hip. Lower drop, less rockered shoes tend to have higher workload at the foot and ankle. However, when we talk, also have to realize that things interplay all the time. And so that's the common thing. I go, hey, if I want to reduce symptoms, I'm probably going to look at a lower drop, less aggressively rockered shoe, but knowing I need to do this, looking at them, because I've also had people that have like no ankle mobility. And I go, oh, let's get a lower drop shoe. And it makes their knee worse because they're actually now having to compensate more. And they're slamming into it. So that's where it's like, and the same thing with the rockered shoe. We're like, okay, cool. Now I took away their ability to actually get forward progression, and they're going to get it from excessive movement anteriorly at the knee to try to maintain that forward stuff. And so like it gets worse. So it depends. I know people hate the phrase, it depends, but just know that it's less set in stone as you get to the knee and even less as you start getting to the hip.
I totally agree with you. When I think about the features, it's rocker and drop and flexibility. So if you have a very stiff rocker, the theory is that shifts load up from the ankle to the knee. If you have a very high drop shoe, in theory, that shifts load up to the knee. If you have a very flexible shoe, lower drop, you're looking at more work for the foot and ankle. But it's not just the feature of the shoe, it's how people choose to run in a different type of environment. So I think that you can take those ideas, and if you're like, I've had recurrent knee pain, take those ideas and maybe try something with it. Like, so go find a more lower drop flexible shoe. I mean, like, I feel like it's just the only shoe I have near me, but like a flexible shoe, like the Flow 2 from Ultra, it's flexible and it's lower drop. That's the exact type of profile shoe that you could consider trying and just seeing, does this actually seem to change how much I feel at my knee? If you don't, maybe a shoe is just not your answer. You've heard us say a million times that shoes are like the 1% when it comes to injury, not the 99. So you got to work on the 99 as well. But this is that extra thing. It's like, okay, maybe go try those out and see if that holds true, for you. So I agree completely. Now let's talk about what sort of tips would you have for somebody who they want to prevent their knee, anterior side of the knee, from bugging them. What would you have them do?
I'm going to go back to the first thing I said, that I think strengthening is really, really important. If you'd asked me this probably...
Wait, hold on. I'm going to cut you off because I have to say one other thing that's really important.
Okay.
If you've got knee pain and you're like, I want to change my shoes to decrease stress on my knee, and you're going to go to a very low or zero drop shoe that's really flexible, but you don't know if you have the calf readiness for it and you haven't been training your foot, you don't want to make a transition from something crazy. Like if you've been training in super shoes only and you're going to go transition to something super flexible, you don't want to do that because that fast transition could lead to way too much stress at the foot and ankle. You could get some issues down there. So transition slowly. Make sure that you do it wisely and get the robustness in your calf and in your foot musculature and the bone structures there before you would just flip the switch too fast. Okay, so what can help the knee?
Do not use shoes as bandages. They're tools. Somebody said something to me that's freaked me out a little bit, but like be wary of the thing that disappears immediately. It's like do we actually fix this? So just like, so if don't like, oh, I had this injury and now I wear this shoe and it's gone. Like, no, you still need to address, like, yes, we're all, runners, but you still need to address the underlying things. This shoe is maybe a piece of this.
Yeah.
And that's why the next couple things, I'm probably not going to be talking that much about shoes.
Right. Exactly.
Probably for knee stuff, one of the most important things that I would consider would be maintaining very, very good strength. And this thing I was going to say is, if you'd asked me 10 years ago, I would have said, oh, focus on hip strength. You'd also need to have good quad strength, good hamstring strength. You need to be strong everywhere. So some good, appropriate loading. And the same thing I talked about earlier, where like, get some good weight through there, get some lower repetition. Don't do your 20, 30 rep, do your lower repetition, be efficient, high weight, some good loading that builds good bone density, that builds good muscle capacity. And we're really working on strengthening both the knee and the hip is really, really, really important. The other piece I would say to that is also kind of like we talked about earlier, make sure you have very good ankle, especially ankle dorsiflexion mobility. One of the things that I teach, because I help teach a prosthetics, orthotics, and gait course, is when you lose dorsiflexion, it's all going to go up. Like tibial forward progression is so important. Tibia, fibula, the major bones of that lower leg, those progressing appropriately is so important for forward gait. You lose that, it's going to load like the knee quite a bit, be it hyperextending it, excessive flexion. So making sure, kind of similar things, that you have good dorsiflexion mobility is really important, but also that you have control of it is the other thing. And the other piece I'd probably suggest, outside of the classic, make sure you got good patellar mobility and good knee joint mobility, is just working on some good knee, ankle, hip stability, right? Making sure that you've got good movement control, making sure that you can tolerate, making sure you're not getting any excessive fast motions that might be annoying if you overtrain. Like, make sure you have good control. How much motion? A little bit less concerning, but do you have control over this? Can you load it appropriately? Is probably one of the more bigger things that I would say. The other piece I will say, just from a shoe perspective, is, make sure you've got a shoe that fits you. Right? Yeah. Make sure it works for you. Make sure because sometimes for some people, the knee is kind of the first thing that kind of goes, this may not be working, or this is wearing out. So, from a shock absorption perspective, make sure your shoes are up to date. But
yeah, that's good.
The first three are probably my bigger priority.
Yeah, that's good.
Anything you'd add?
No, I've been debating on a few things, but
let's hear it.
The ones I was going to say for sure was enough ankle dorsiflexion mobility. And then I was going to say, from a strengthening perspective, the really heavy tissue loading, really getting some Bulgarian split squats that are heavy, or just like, or a regular squat that's heavy, and then some hamstring specific loading. And then I was going to say like glute control type exercises. So doing kind of lunges where you're really focusing on form, not because you need to move like that all the time, but it forces your muscles to coordinate with each other and work, and just getting your brain involved in that is important. So like, if you're a runner and your knee kind of moves in and out and you've never had issues, that's not necessarily a problem. Like, watch Conor Mantz run, right? Like he probably has femoral anteversion or something that like puts him into like the position that he's in. But I think it's good to work on the hip for that control mechanism and like having that stability. So stability exercises, heavy lifting, ankle dorsiflexion. Yep. What I'm hesitant to say, but I'm going to talk about it. So this is maybe not fully what I think, but it's something I think about. And I sometimes apply to runners in specific circumstances regarding like healthy knees. If you're a newer runner, I would consider paying attention to some of your running form things. So I have the privilege of doing gait analysis on every freshman that comes through the cross country team. And then we also get to do a running analysis on lots of other runners too. Something very common that I see in the freshmen who have recurrent knee pain is a really, really low cadence. So there's not like a perfect number for cadence, but they have a very low cadence, like 150s, like mid 150s. And they also overstride a lot. So they reach really far out in front of them. And that combination puts a lot of stress on the knee. and I think contributes to some of their issues. And so if you happen to run with a running watch, again, I'm being so cautious with saying this right now, but just kind of take a peek at your cadence. And if you're in the 150s, maybe chat with a PT about that, who knows running, and see what they would say about if you wanted to try to change your cadence, what might that look like? Because there are studies that show with this is from Brian Heiderscheid's lab in Madison, if you increase cadence by 5 to 10% from your self-selected cadence, so just like what you normally pick, there's significant decreases in patellofemoral loading. Those peak loads go way down, and overall workload at the knee shrinks by a good amount, both at 5 and 10% above your self-selected cadence. And so that would be the other thing I would consider. Usually over the first 3 years of running, people's cadence increases naturally without any retraining. You just kind of learn how to run if you are getting into distance running. But if you're someone who's had knee issues in the past, maybe you want to prevent it from coming on, you notice that you do have this really low cadence, that's one you might want to consider. But I think that any sort of gait changes are really nice to do with a team, just because you don't know what those changes are going to do. So what's your reaction to that?
Can I challenge you on something that I'm
for sure
working on right now?
Yeah.
So I have the privilege of having a lot of people that are smarter than me challenge me with things. And so a lot of my research, because I do biomechanics, is looking at like, hey, how are people moving and stuff like that. And so in my PhD, we chose some pretty basic stuff, i.e. moments, which is like rotational forces essentially, and powers at each joint, ankle, knee, hip, looking at mouse runners, Achilles tendinopathy. I'm now moving to the next stage of my research. I'm okay, I'm going to look at other runners and do other stuff. And one of the challenges has been going, are these really important variables? And I'm like, well, obviously it's like foundational biomechanics. But when you start looking at what's actually predicting injury performance, it's not, right? And that's where all this stuff is coming out, whether it's talking about something called impulse or the thing that my brain is really on right now, which is called the reactive strength index, going not just how much force do you produce, but what do you do with it? Like how quickly can you get back off the ground is where my brain has been challenged with to look at. And what I've been thinking and sitting going, I wonder if, because people that tend to have a lower cadence to a longer stride have a much longer ground contact time.
Yeah, that's a good point. Like duty cycle.
Yeah, the duty cycle. The other thing is going, I wonder if that has anything to do with their power and their ability, their reactive strength. It is a better term than power, to be able to get off the ground quick. And just that's their movement strategy. So sometimes I wonder, when we change cadence, are we looking at the right thing? And are we giving them all the variables? Because it's the same thing with shoes, right? Like, I know Brian maybe doesn't want to, like Brian Heiderscheid doesn't want to hear this, but like if you change this bigger variable, what are the other things that happen that maybe you have it conditioned appropriately? Like, did you teach them or give them the capacity to actually move their legs faster, right? That's greater power. It's like, you got to be able to get muscles to contract a little bit quicker, not necessarily as generating as much force that you have to do with a longer stride and landing really, really hard, but you got to get things to move quicker. Is there a potential that you've just switched? And that's, I think, where you're hesitating, going, did you just switch the loading instead of actually addressing it? And so that's where going, does this group, and I don't have the answer to this. This is the things that are rattling my brain, because I'm, unlike you, I'm trying to get access to our cross-country team. I got to talk to some people, and I'd love to be able to take a look at them every year, but we don't have that relationship yet in the George Fox PT department. But I would love to I'm asking some of these questions going, where do we need to look at? And if you change these things, is cadence going to fall in? Or is that a separate motor control problem?
Right.
So that's where my brain's going, what variables do we need to look at?
Totally.
And I'm just confused now.
Yeah, totally. And I think what's promising from what we currently know about changes in cadence is that most of the metrics that have been studied so far, the amount of demand goes down on pretty much everything. What goes up is mental involvement and fatigue due to cognitive demand. So like your running economy goes down when you first change cadence, because you have to work really hard to change your movement pattern, because it's, I don't know.
And that takes a while.
It takes a while. When we run or do any sort of what's called a continuous task, walking and running are two examples where you do the same thing over and over. Your body doesn't do that in the same way that we throw a ball. Like when we throw a ball, we have like a specific way that we use the movement patterns. When we go run, our brain says, activate running sequence. This is oversimplified, but it says activate running sequence, and you just start to run. And to change that running sequence is so difficult because it is not in our like frontal cortex. It's not something that we're actively focusing on doing. It's just something that happens. It's subconscious in some ways. And so that becomes really tricky. Cadence is easier to manipulate because your brain can make the changes by running to a metronome, for example, but it's still a lot of mental work and makes you feel like a really fatigued runner.
Right. This is also my hesitation a lot of times with things like foot strike, and people I know it's a go-to. Like, change that.
Right.
And I'm like, the changes and the amount of time involved in transitioning to that, making a permanent movement, and the fact that most people have no idea how they're actually landing, even when they're trained well, is like, so I'm not saying it's wrong. I'm just saying sometimes like, do make sure my priorities are like load management, going, can you tolerate the load, things like that. And some of these can be helpful to change stuff, but like movements is difficult. Movement is really difficult to change.
It is. Fantastic. Well, thank you all for coming on this journey with us. We would love to hear if there have been things that have been really helpful for you in managing your foot pain that you've had in the past, or your knee pain that you've had in the past, or just this kind of routine that you've gotten down that you found is really helpful for you. Feel free to let us know what you've been thinking and doing. And we look forward to future conversations about how shoes may play such a small teensy-weensy role in management of conditions, and also talking about the bigger pieces, like what can we do from an exercise perspective, and then even bigger than that, our overall lifestyle habits are way more important than even one small exercise. So again, thank you for coming on this journey, and we look forward to talking to you next time.